hopefully some of our little marathon will try they stayed in your brain. I guess we're, question 1. Do we know what HAGMA stands for? Question 2, what causes HAGMA? What do you think? Alpha, yeah. Uremia is one of the causes of HAGMA. It's in that gold mark mud piles, right? Acute renal failure leading, end-stage renal disease, uremia. Vomiting, if we're throwing up our acid, what is that going to cause? We're losing acid, like physically losing it, alkalosis, right? Ibuprofen. Diarrhea and acetazolamide will cause a normal anion gap or a non-anion gap acidosis. Metabolic acidosis that can be treated with normal saline. Remember, chloride responsive, chloride unresponsive. Okay? Which one? No. But think about why. What is diarrhea going to cause? Acidosis or alkalosis? Acidosis. Bicarb-rich diarrhea, right? Acidosis, non-anion gap acidosis. Remember, if they don't have diarrhea and they have a non-anion gap acidosis, they probably have one of those renal tubular acidoses, right? So, failing that, which one of these things is something that you could treat a patient with a bag of normal saline? Suctioning, right? Same thing as vomiting, right? That's the thing, throwing up our acid. We're getting rid of our acid. Either we're sucking it out or the patient is throwing it up. Very good. The rest of them, osmotic diarrhea we talked about, renal disease and Bartter syndrome, and aldosterone secretion. All of those things are going to be intrinsic diseases that are not going to be treatable by a bag of normal saline, although we may temporarily make the problem better. We're not going to fix it, whereas vomiting fixes the problem. Okay. Yeah, I know. E should be like, give me a break. But again, this is why I do these little questions, so we put these fine points back on. Like, this is anybody remember? It is type 1. Okay, we talked about it first. It's type 1. It has to do with hydrogen, and it has to do with kidney stones. Patient has kidney stones. Okay. Type 2 is the other one that has to do with bicarb. Type 4 is diabetic nephropathy, has to do with diabetic nephropathy. Type 37 I made up, and type 3 is basically a clinical non-entity. It does exist, but we didn't even talk about it for a reason, okay? All right. Ready? Here we go. Just remember 35 to 45, 35, 45, 7, 35, 35, 45, and 23, 26. Here we go. Got it. And if we need to, I'll go back. But I told you, as you're reading, as we're reading, right? Do you even need to read that? Theoretically, as I told you, no. It might help you if you're for some reason, if like Rome flies out of your brain, the clinical scenario might help lead you towards which one it should be. Okay. But we have a pH that is which way? Acidotic. It's too low. Okay. Bicarb. It's supposed to be in the 20s. If you don't remember 23, 26, it's supposed to be in the 20s. So is bicarb high or low? Low. So what do we got? What kind of acidosis? Metabolic acidosis. That's it. 2 steps. You got there, right? Okay. Make sense? Anybody? Does it not make sense to anybody? Okay. Have that painted yellow. I mean, anybody who stopped reading at COPD and guessed the answer, you're probably right. But just in case, the pH, which way is the pH this time? Still acidotic, too low, right? Which way is the bicarb this time? Too high. What do we got? Yeah, respiratory acidosis, because we got acidosis. 2 steps, okay? Okay, pH 735, 745. It is too low, so we're at an acidosis, right? Bicarb, it's probably just change it from 17 because we had 17 in another one. It's low, so what do we got? Metabolic acidosis, right? Straightforward. That's the level of acid-base disturbance you need to be at. Deciphering these problems. Now there's going to be other types of problems. I put other layers on it, like this patient has this clinical scenario, what kind of acidosis would you expect, or what kind of acid-base disturbance might you expect? Those should be pretty straightforward from the reading, all right? Or from everything that we went to, okay? But as far as like deciphering AVGs, deciphering true acid-base disorders, this is where we need to be, primary, okay? Everybody, does that make sense to everybody? Okay, I hope so. And if it doesn't, please let me know. So, any questions about the stuff we had? I know it was a whirlwind. Good times were had by all. All right. But we did also our pre and post renal. All right, we just left off at intrinsic renal disease. All right, so what is the picture, what is the etiology, like one word, what is the most common way to conceptualize what is the most likely patient that's going to have a pre-renal disease? Dehydrated, hypovolemic, yeah. Easiest way to understand. A hypovolemic patient for some reason. Flowers aren't getting enough water, but they're not dead yet, right? So what does that mean? Labs look like labs would look for a patient that has a functioning kidney. BUN goes which way? Up. Creatinine is where? About the same. Stable-ish, right? Don't let a little bit of a bump throw you off, right? If it's 1, 1.8, whatever, that's still. Creatinine's 45-50, or BUN's 45-50, creatinine's 1.8. Ratio still high, right? We got it, even though creatinine has gone up slightly. Are we conserving sodium or are we spilling it inappropriately? We're conserving it. Kidneys are functioning. Kidneys are working, doing what they're supposed to be doing. Is our urine dilute or concentrated? Concentrated, because we need fluids, right? Kidneys are doing their job, right? Post-renal looks the same, except the problem here is what? Obstruction of some kind, yes, downstream, outside the kidney. Whether it be in the ureters or below, whether it be in the renal vein, doesn't matter, there's an obstruction to outflow. Okay? And eventually, on a long enough timeline, it turns into, both of them turn into this. Intrinsic renal disease, right? Kidneys aren't allowed to function because they're hypovolemic for a long, prolonged period of time. Eventually, ischemia becomes necrosis, right? What things can you tell me already just about a lab, a microscopic urinalysis, that we would expect for a patient with intrinsic renal disease? Let's say acute tubular necrosis. Acute tubular necrosis. What kind of cast? Tubular cell cast. You're right. Yeah, tubular cell cast. What else? Just loose tubular epithelial cells. Protein, probably. Maybe a little blood. Okay? Fractional excretion of sodium. What do you think that would be? If the kidneys are now not functioning, and are we holding on? Are the kidneys doing what they're supposed to be doing? Fractional excretion of sodium. We're expecting it to be high. We're spilling sodium. Urine, concentrated or dilute? Dilute. Right? So you can come up with all of this stuff just by understanding that that stupid little sad kidney can't function anymore because it's dead. All right? Or dying. Let's put some layers on that. So again, renal parenchymal damage. Again, that's what we're talking about. You know, acute tubular necrosis. The other one is we haven't talked about is acute interstitial nephritis. Intrinsic renal disease, kidney failing to function. This is why they used to call it acute renal failure, because that's what's happening now. So if that helps you remember it, intrinsic renal disease, that's what's happening. The kidney is failing acutely, all right? Acute tubular necrosis. We meant, you know, I don't know if you remember the beginning of this particular slide deck, we talked about all of those risk factors for these two diseases, both ischemic and nephrotoxic. We had that whole list of anything that might cause renal ischemia, hypovolemia, shock for some reason, and then nephrotoxicity for the nephrotoxin. So acute nephrotoxicity, whether it be endogenous, like something like myoglobin or hemoglobin in a profound hemolytic anemia, or exogenous, like something we give the patient, a medicine, which is usually what causes the nephrotoxicity. And then AIN, acute interstitial nephritis, we're going to talk about, and I'll give you the highlights of how to remember that one. And then the whole next lecture, like when I get to the bottom, we're going to see acute glomerulonephritis. And I'm going to skip right through it because the whole next set of slides is all about glomerulonephritis. Okay? But if you want to put on a scale which one of these things you're likely to encounter more common in clinical practice, it's this one you're most likely to see. Second, and then acute interstitial nephritis becomes fairly zebranic, and so does acute glomerulonephritis, although IgA nephropathy is becoming more common. Okay? So acute tubular necrosis. Two main types. Done. And again, the easiest one to conceptualize is that prolonged hypovolemia. But now we're shutting down. Okay? Perturbation. I couldn't help. Love that word. Put it in there. Right? Perturbation of renal blood flow. Right? Disruption. Right? No renal blood flow. And so eventually, that whole top statement is exactly what I've been saying. Ischemia, arrow, now we're in necrosis. That's what that is. All right? So this list, in case you guys are, oh my God, there's a whole lot of words on this. It's the same, just anything that you can conceptualize that would cause an impairment of renal blood flow. You don't have to spend a whole lot of time figuring out these mechanisms. What you have to understand inherently is what would potentially lead to a disruption in renal blood flow. And that is a risk factor to lead to acute tubular necrosis. Does that make sense? But it's all the stuff we talk, shock of whatever kind, sepsis of some kind, major surgeries, physical loss of blood due to injury or trauma, that kind of stuff, okay? And then nephrotoxic, this is the more nebulous one, but you guys, I actually see this in the form of rhabdomyolysis, right? Usually around Memorial Day, usually when it's time to do the MRF, and everybody's gonna dust off that shit, knock it out, and then they're gonna come to you the next day because they can't bend their arms or legs. I'm like, I don't know what's going on, doc. I'm like, I know what's going on. You're dumb. So, so just be, rhabdo, preventing your soldiers, sailors, or whatever from getting rhabdo is going to be a surprisingly big part of your job, but it's true. So exogenous means exactly that. Most of the time this is iatrogenic. We give the patient something, it has an effect on their kidneys, usually because this patient already has established kidney disease and we didn't do our diligence and dose adjust or talk to the clinical pharmacologist for their renal clearance, like EGFR. Endogenous, honestly, like in this population, this might be more likely because you almost certainly will see rhabdo. But everybody thinks about CrossFit when we say rhabdo, right? What are some other real causes of rhabdo that are associated with profound muscular breakdown? Running. Yeah, running, exercise. Okay, besides exercise, like what are some other, besides exercise-induced rhabdo, what else do you think? Burns, what else? Electrocutions, crush injuries, what else? Seizures, meds potentially, but yeah. And then also prolonged immobility. Somebody falls down, passes out for some reason, like somebody gets drunk, falls out, lays on their arm the entire night. You get muscle breakdown, so you can get rhabdo from that. All right, so little things that you might not always think off the top of your head. Most people do associate with exercise, yes, but there are a myriad of other reasons for our less than, people who exercise less than normal, right? That's what we'll say. Gout and then paraproteins, Bench Jones, you'll talk about, I'll briefly mention Cas nephropathy in here, but that again has to do with plasma cell myeloma. But I don't think you guys talking about rhabdo anywhere else, so we're going to talk about it real fast here. But what's the real problem? The real problem is myoglobin. The real problem is muscle breakdown. And the myoglobin specifically, because the myoglobin is a protein that is not freely or easily filtered by the kidney. So the way I always think about it is like, imagine the cogs of a wheel turning, right? And then you just pour a bunch of syrup into it, gums up the works. So that's what happens essentially, colloquially, in myoglobin. It's directly nephrotoxic, so it causes a direct tubular injury, but essentially what it does is just glums up the nephron so that it can no longer function, it can no longer filter like it's supposed to. So when you have this profound muscular breakdown and all this huge release of these sarcoplasmic proteins, the myoglobin, kidneys are the ones that shut down, right? The other thing that's a problem, what's the other problem? Is it on here? Electrolytes, but really, which one do we really usually care about mostly? Potassium. Like a big potassium release is a big potential disruptor for our, conduction. So that's no good, right? So it is an emergency in many cases, okay? What do we have as the symptoms, right? Muscle weakness, stiffness, swelling, right? You can get compartment syndrome-like symptoms where you have distal neuropathies because you have this profound swelling in your proximal musculature, so your fingers are numb, okay? Then you have you have symptoms of muscular breakdown in your kidneys. So what is your urine probably going to look like? Brown, dark, right? Coca-Cola, tea, whatever you want to call it. And then what is a likely thing you're going to see? You're going to see a false positive hematuria. Why? Because it's myoglobin that's going to turn the dipstick positive, but a microscopic analysis might not show any red cells. Oftentimes there will still be red cells. It will be a true hemoglobinuria, or a true hematuria, excuse me. But just understand that the reason why the urine is so dark and so ugly is that myoglobin is in there, okay? And let's see. These are causes, so you can talk. We listed most of these. You don't have to, again, memorize this entire list. Everything we just talked about. Global stress on the body, crush injuries, prolonged immobility, exercise, of course, so on and so forth. That's what's going to cause it. And so, tubular obstruction, that's the gum up the works part that I was talking about. It really literally blocks up the tubules so that you become oliguric or even anuric. The glomerular filtration is not occurring. And then there is direct nephrotoxicity because of the myoglobin protein itself. So you have a direct kidney injury. So technically we have a nephrotoxicity. And then hagma, why? What's the other? In hagma, what's going on? Something else that we haven't measured, right? An unmeasured anions causing a huge anion gap. What is the unmeasured anion likely in rhabdo?
Protein.
Huh? Lactate. Lactate, most likely. Okay? And see, this is the same mechanism the TAM horseball. You guys remember what that is, right? That's that skeleton that forms cast, right? But instead of the cast sloughing off, it's just stuck. This big protein just stuck. All right? This is just visual representation for those that helps. That's what it's there for, okay? So that's rhabdo. General signs and symptoms of acute renal injury are usually still not uremic type symptoms. They're still usually not physical overt signs and symptoms of kidney injury. They're the signs and symptoms of whatever is causing it. Does that make sense, everybody? So what the patient is going to look like, it's the signs of hypovolemia, it's the signs of sepsis or shock or whatever other reason they're in hypovolemia for. It's the signs of rhabdomyolysis, or it's the overt signs and symptoms of muscle weakness, dark urine, but that's about it. Kidney injury doesn't typically walk in as kidney injury, right? Does what I'm saying make sense? Okay. So again, all of this, is any of this what you would call probably, besides maybe oliguria, is anything really specific to kidneys there? Not really, right? It's what else is going on. And I think at the bottom of your slides, it was a note to myself that says, put in rhabdo-specific labs. And so I did. Too late. But anyway, creatine kinase at 5 times above normal is what our definition of rhabdo is. Now it can go well above 1,000, and it usually does into the six digits, depending on the severity. But that's neither here nor there. Just understand that if we're thinking rhabdo, that's another lab you should consider getting. So that's why that white box is there. I do apologize that I didn't make the note myself, but everybody got it? Okay. And because it's not on your slides, it won't be, that specific creatine kinase won't be on the exam because it's my own fault, but I just want you to know, okay? Not that rhabdo won't be, but that lab value won't be. Anyway, general other signs and symptoms, right? Everything we've already talked about. Active urinary sediment, stuff in it, renal tubular epithelial cells, CAS, and then don't forget our friend Muddy Brown. Right? Muddy Brown isn't specific, but it's very commonly associated with this. Differing amounts of urine output decreasing, and as we decrease urine output, we decrease prognosis, right? It gets worse and worse, and that should make sense. Kidneys that can still make urine to some extent are healthier than some are just completely have given up the ghost, right? BU and creatinine ratio going down, right? Why? Creatinine going up, exactly, right? Fractional excretion of sodium and urine sodium both going up. We are inappropriately wasting sodium in light of a typically hypovolemic or kidney injury state. Most of the time, like we've already said, our urine concentration will be low, right? Like our urine specific gravity will be low, osmolality will be low, which means we're dilute urine in the face of a hypovolemia, which is not right. And then hyperkalemia is often. Clinical course, like how does it, like this is critical care. Like acute tubular necrosis are very sick patients that need to be monitored. If you think about it, just in general, your kidneys are shutting down. Think about the things that the kidneys are doing. They can no longer do those things. How much does this patient have to live if we don't take care of those issues for them? Replace fluids and electrolytes. Potentially dialyze this patient. Give them fluids. Monitor their fluids to make sure we're not fluid overloading them. Help the kidneys along. Make sure that we don't give any kind of nephrotoxicity. So again, this is an inpatient medicine here for acute tubular necrosis. And hopefully that makes sense. But not a good clinical picture. That just also depends, right? If you look at this, let's say it's a case of rhabdo and somebody in here just does a little bit too much, whatever exercise, kidneys shut down a little bit, maybe not even get to this point, but let's say that they do. That patient's going to be all right. You guys are going to be all right. But let's say it's a 85-year-old nursing home patient who develops a pneumonia, then becomes septic, and then their kidneys shut down. You think they're going to come back? Most likely not, right? So it can be a pretty morbid disease. Clinical course, just so you know, it's divided in phases. It's not super important, but just in case you see it, it's the initial phase and the extension phase. So it gets, the injury happens, and then the kidney effect really starts to decline. So the initial insult to the kidney, and then its net effect as GFR starts to decline and all those labs start to develop like we just talked about. Maintenance phase is where this patient will start to stabilize. Their labs will start to normalize a little bit, right? But they're still not out of the woods. When they recover, I have a baby giraffe on here. Everybody see like a baby giraffe or a baby deer try to walk? It's all googly, it can't do anything, it falls down, right? So that's like what the new renal tubular cells that are being produced are like. They don't do their jobs right. They can't filter electrolytes correctly. Tubular secretion reabsorption is off. So you have a potential huge diuresis. Now you have this patient who is already volume low. We managed them. Their kidneys are recovering. Now they're starting to pour out fluid. Because essentially, like I said, the baby giraffes can't do what they're supposed to be doing. So that, when you see a huge diuresis, that patient is getting better, but they're still not out of the woods. Why? Because we have to manage their fluids and electrolytes very closely to make sure that they don't dip back into a hypovolemic state, right? Does that make sense? A little bit? That's really all you need to understand, just the generics. Injury, extension of the injury, stabilization, getting better but not out of the woods, and then they're all better if they make it out, okay? If you like a picture, there you go. Okay, same thing. But this is the problem, right? Dedifferentiation, redifferentiation. So that's what's happening. Cellular redifferentiation. You know what differentiation means, right? It's becoming different from its surrounding cells. It's becoming what it's supposed to be. But that process happens slowly. It's like a stem cell, if you want to think about that. It's just a generic cell, kidney cell. Water's going through it, electrolytes are going through it. This person's losing volume until that redifferentiation takes place, and now we have real tubules doing their real job, and that patient is better, okay? That's where they gotta go. I see you, right? Rhabdo, most of the time, not going to be bicarb, still mostly going to be fluids, maintaining urine output, trying to flush, really flush the system. We want to make sure that we are pushing that crap out of there if we can. Really paying attention, obviously, to their potassium level. That's a real danger here. Keep an eye on their kidneys. Does everybody who has rhabdo need to be admitted? No. It depends on the severity. It depends on the comorbidity. It depends on the patient in front of you, all right? So it's a clinical decision-making process. So if you're like, well, what are you going to ask in the test? I'm not going to ask you treatment. I'm not going to ask you disposition questions, like should this patient go home or stay with you, all right? So don't worry about that. It just really is a clinical, is this patient in front of you able to go home? Are they stable? Is their cardiac physiology stable? Or do we need to watch them, all right? Does that make sense? Okay. Any questions about tubular necrosis? This one's gonna go a little bit faster. Interstitial nephritis. What is itis? Inflammation. Yeah, that's really what this is. This is kind of an allergy-mediated reaction. So if you think allergy-mediated reaction, what do you think one of the symptoms is going to go with this patient is going to be? Rash. Yeah, there you go. What blood cell lineage do we expect to be increased in inflammation, or allergy-mediated inflammation, I should say? Eosinophils. Yeah. There you go. That's what makes this one stand out. Seriously, in a nutshell. Okay? Everything else is the same. It's intrinsic renal disease. What are all the labs going to look like? Just the same. But what are the casts going to be in this one? Eosinophil casts. Not acute tubular necrosis casts. Right? Does that make sense? Otherwise, it's going to look pretty much the same. Fractional excretion of sodium, off. Urine sodium, off. BUN creatinine, going up. Ratio going down. But now, what's going to make this one differentiate? We have eosinophils. Eosinophiluria, eosinophilia on a CBC, and eosinophil cast. Okay? Make sense? I'm giving you the labs. I'm giving you like the punchline before I tell you the joke. Does that make sense to everybody? Okay. And usually a lot of ones, truthfully on here, drugs mostly. All right? If you see it, and you won't. It's usually drugs, and usually it's antibiotics. Okay. It can be other things, but most of the association of this is some sort of allergy-mediated reaction to a drug, and it is not anaphylaxis. I want everybody to understand that. This is not an acute anaphylactic shock type situation. This is something that's going to do precipitate an attack on the kidneys. Create inflammation. This patient will come back a couple of days after they've initiated the medicine, and they will feel sick and like down, fatigued, muscular weakness, myalgias, dark urine, and that's how it is. So it's not an acute presentation. Does that make sense to everyone? Is that clear? Okay. So don't confuse this with anaphylaxis. That's not what it is. Classic triad: rash, muscle aches and pains. Right, myalgias, arthralgias, and then fever. So patient started taking a medicine, they develop a fever, muscles and joints start to ache, they might have a rash, they start to pee dark brown. They come back, we do our diligence. Have you started any new medications? Yes, as a matter of fact. All right. Eosinophilia, right? What does pyuria mean? Huh? White blood cells in the urine. White blood cells in the urine. In this case, they are eosinophils. No parasites, allergy. Eosinophils, okay? And hematuria, dark urine, okay? And I know you guys haven't even touched derm yet, but you guys have seen like an allergic reaction, right? Contact derm. Let's just think, allergic reaction, rash, just, morbilliform rash, maculopathic. So what is a macule? It's a small, little flat skin lesion. The papule is a bigger one that is raised, right? So it's a bumpy, itchy, red rash, yes?
Is this related to Stephen Johnson's attend at all?
No,
Okay.
it isn't, no. But it's I mean, Stevens-Johnson, is an acute, necrotizing, skin sloughing off. It's treated more like a burn. It isn't also a medication reaction like Stevens-Johnson's. A lot of time goes with like Septra, but two different sort of pathophysiologies. This one is an attack on the kidneys and some peripheral allergies, but the desquamation doesn't happen.
Okay, thank you.
Yeah. So, like I said, everything else kind of looks the same, right? Except these guys, right? Side by side, what's the difference? First of all, the patient's not nearly as critically ill. Second of all, the patient doesn't have a history of any kind of hypovolemia. It is still nephrotoxic, so how would you differentiate between nephrotoxic and tubular necrosis in this? One, the acuity of the presentation, two, the labs, right? Different types of casts, different types of cells. Fair enough? All right. How do you treat it? If it hurts when I do that, stop doing that. Whatever medicine they're taking, take it away from them. And in many cases, the patient will need to be seen by, in all cases, the patient will be seen by nephrology. They may or may not need to be inpatient. It really, again, depends on the patient in front of you, right? So I'm not going to ask disposition questions on what might be a nebulous disposition, okay? But the morbidity and mortality of this compared to ATN is significantly lower. So these patients typically do just fine, okay? Okay, that's the end of this one. Vascular AKI, we're going to talk about this in our vascular lecture. This is what we're about to get started talking about. This is the chart with pre, post, and intrinsic renal disease labs put right next to each other. So if it helps you to go side by side by side, there it is. This is a flow chart. This is a picture. This is cardiorenal syndrome, and I'm going to talk about this a little bit as in a very superficial manner. Okay, and the reason why is because if you look at the diagnosis of cardiorenal syndrome, this in my opinion, is what you call a chicken or the egg question. AKI from cardiac disease, CKD from chronic disease, cardiac disease from AKI. Right? Which one came first? How do you tie that down? A really long look at the patient's labs from a long time ago to see when GFR is going to go down or when their cardiac surgery. So it doesn't matter to us right here. And you guys, it doesn't matter. What does matter? If they have renal disease, be it acute or chronic, pay attention to their heart. If they have heart disease, pay attention to their kidneys because they're going to start fighting. All right? And that is cardiorenal syndrome. That's as much as we need to talk about now. We'll talk about it more in chronic kidney disease. All right? But again, the biggest thing, prevention, I do love to talk about prevention in here, especially when we talk about kidney disease. Just make sure that you are aware of your patient's renal status. Definitely your pre-op patients. If you have a patient population that you see that's not your typical healthy patients like you might see at sick call, make sure you make any kind of necessary renal dose adjustments. Because again, it's not necessarily the de novo, right? Acute injury. What it is the acute on chronic. It's the person with established chronic kidney disease and other comorbidities that we accidentally push over into acute renal disease. And even if they make it through that acuity, their renal function has gone from here and we've stair-stepped it down, right? So we made the patient way worse. So just be careful of any necessary renal adjustments. Any questions about pre, post, intrinsic renal disease? We're going to go on to our glomerulonephritis diseases next. Nope. All right. Fair enough. So glomerulonephritis is a long slide deck, but I'm going to highlight for you. And again, it goes well side by side because we're going to talk about generally nephritic and nephrotic disorders. You probably mentioned them before in pathology. You might not remember it at all. But I'll tell you before the slide gets up here. If we're talking nephritic disorders, nephritis, okay? We're talking about blood, hematuria, red cell cast, acute glomerulonephritis, blood, okay? Blood. Hypertension, minor swelling. We talk about nephrosis. What did I already say? Nephrotic syndrome. Huh? Protein and and fat, and big swelling, right? So we go blood, minor swelling, hypertension, to protein, fat, major swelling, okay? That's clinically how you tell them apart, labs and patient in front of you, okay? Most common presenting complaint of a nephrotic syndrome is going to be an acute onset of facial swelling. And it's going to be mostly kids. They're going to come to you, they're going to have a swollen kid. You're like, what happened? Most common presentation of glomerulonephritis is going to be an acute onset of painless hematuria. Blood, protein, and swelling. Okay? Before we even get started, does that make sense as we start to march forward here? No? Okay. Some terminology, like I said, we already know oval fat bodies. Okay? Those are the things that look like Maltese crosses under a polarized light. Fat bodies, so what do they go with? Nephrosis, exactly. Yep. And then crescents, you guys know Bowman's capsule, right? And then the glomerulus inside. There's that space, the capsular space. When that is filled with red cells, it's in a crescent shape. That's crescentic formation. That is the sign of acute and progressive, rapidly progressive glomerulonephritis. That's bad. Okay? So just in case I use those terms, or when I start to use those terms, as we move through the slide deck, that's what they mean. Okay? Just so you can kind of visualize. Big buckets. Nephritic syndrome, nephrotic syndrome. Two sides of the coin, but of course there's a spectrum. Are you going to see some red cell spillage in nephrotic syndrome? Yes. If the glomerular permeability is such that we're losing proteins, does it stand to reason a couple red cells might squeeze through too? Yeah. Okay. Oh, may we see some proteinuria, minor proteinuria in nephritic syndrome? Yeah, we're talking about glomerular injury and altered glomerular permeability, right? Swelling is going to be on both sides of it. More acute on one side, less acute on the other. Hypertension will probably be on both sides. More acute usually in the nephritic syndrome. So you see what I'm saying? Don't miss the forest for the trees when it comes to actual clinical diagnosis, or especially test questions, right? Don't let a little bit of something that kind of looks like something else distract you from the big thing waving over here of what it actually is. Okay? So I am going to talk to you about some some pathobiological findings in here, because you're going to see them on the pants and the paprat. We're going to ask you, like, you see, mesangial and immune complex deposition or subepithelial humps, and those words will make sense in a minute. But I used to not, but I've seen more and more and more. Pants is going to have these questions on there asking you about sort of the microscopic findings, even though you'll never see it under an electron microscope. I just want you to know how to answer those questions, all right? So, this is what I'm talking about. In order to really tell, they present very similarly. Some of them look almost identical in a clinical presentation. Renal biopsy is what's going to tell us exactly where the site of injury is, okay? Which again goes back to what we were talking about even in the acute kidney injury. If we can get markers, biomarkers, that tell us where the site of injury is, that go along with the clinical presentation, then we don't have to punch a hole in this diseased kidney and the patient is better for it. So anyway. So here's them side by side. So like I said, makes sense? Blood, hypertension, edema, mild. Proteinuria, low serum albumin, big swollen, and fat. Okay? Itis versus osis. It is a spectrum, okay? It is a spectrum, but we're going to clear that up. And we're going to talk about things that clearly fall into one or the other, all right? These guys, honestly, everything on this in that spectrum, that gray area you might call the middle, is why I said don't ever let proteinuria or hematuria go without being solved. Because you could have somebody that might have had IgA nephropathy, never was diagnosed, didn't even know it. Now they just have microscopic hematuria and their EGFR is low and their BUN just keep creeping up, and so does their creatinine. Nobody's ever even paid attention to it because they're young and they're healthy and it doesn't really matter. But what you might be seeing with that microscopic hematuria that you get because they're going to ranger school or something like that is the first sign of chronic kidney disease that nobody's paid attention to yet. So again, blood and protein, don't let them go unexplained. Nephritic, we're going to start with nephritis. Inflammatory, itis, right? Itic, inflammatory. All right. So, hematuria, glomerular source of bleeding, right? This is not a post-renal, this is an intrinsic renal disease. Remember that we are still in the intrinsic renal disease category, okay? So, bleeding, RBC CAS, and the red cells that they see are often dysmorphic. What does that mean? It means they're not the right shape. Just think that they've been filtered through something they've squeezed through and now they look all weird. It doesn't really matter. Blood and blood cell counts, red blood cell counts. Hypertension, anemia, everything I've already said. And again, don't miss the forest for the trees. 2+ proteinuria, 1+ proteinuria, it's going to be there most likely. But that's not nephrotic range, and the clinical picture doesn't fit nephrosis. So don't let that little, well, there's some protein in there. He said nephrosis fits with blood or protein, so I'm going to answer nephrotic syndrome. Don't chase the rabbit, okay? You see what I'm saying? Subtypes we're going to talk about. It just depends on the area. Those subtypes are categorized into basically what is causing the inflammation, what is causing the injury. Primarily, we're going to focus on immune complex and anti-GBM, all right? So, anti-GBM and immune complex, autobody, right? Anti-autobody, right? Or auto-antibodies, geez. Maybe it's time for my break. All right, anyway, so focus mainly on these two because they're the most common. You guys talk about Goodpasture syndrome in Palm a little bit? Okay, that's what essentially this one is. General characteristics. I'm going to have these again on the slides when we talk about the individual pathologies, but is globally, nephritic syndrome, regardless of the subtype, is going to have these. Dark urine, which is usually why the patient comes in. If we're talking about one of the more classic types, or the less serious types. Usually it's going to be a hematuria presentation. And then all of the same labs. Right? Any of these labs don't make sense. Okay? Don't forget about this. Itis. There will be some white cells. Okay? Will there be white cell counts? No, there might be some white cells, because this is an itis. This is still an inflammatory condition, and an inflammatory responder, white cells, will be there, okay, but this patient doesn't have any type of infection or anything like that to suggest, right? Other variables, they might have leukocyte-esterase, so they will not have nitrite. Again, little minor things that might throw you off the trail. But the big overwhelming picture here is bloody urine, bleeding in the kidney, such that we're causing it to form CAS. Azotemia, you guys remember what I'm talking about? All right. What's our markers of azotemia? BU and creatinine, yeah. Okay. So BU and creatinine increase, right? The GFR is going down, and the BU and creatinine ratio is going down, because the creatinine is going up, all right? And we're going to tie these in to other specific pathologies when you might need some of these additional labs to really exactly find out what is going on with the patient. But anti-streptolysin O titer, you guys talked about complement anywhere else? The complement system, basically a complement to the immune system, like complement is activated in response to some sort of immune insult, right? So sometimes our complement levels, right? Remember, immune complex mediated is one of the subtypes we talked about here, so our complement levels may be useful diagnostic information. Anti-GBM antibody is going to be one of those ones that it just tells you what it is. And if it's there, it's there. If it's not, it's not. And then the rest of them we'll talk. I know it's almost break time. Admit, maybe, it depends. We're going to talk about which patients might need to stay with us and which patients not. Again, treatment decisions like dispositions, I'm not really that worried about. I'm worried about you seeing the big picture, and it really does, because dispositions depend on the patient. You might have somebody who's perfectly healthy that needs to be admitted, and somebody who's comorbid who probably don't. So it just depends. But if we have somebody who's serious or rapidly progressive, let's talk about somebody we have to keep. Obviously, this is still the intrinsic renal disease side of the house, so we still have to monitor their ins and outs. We still have to monitor fluids, electrolytes, acid, base. It still can be critical care medicine depending on how bad they are. But itis, right? What goes along and cures the itis in many cases, like for example, arthritis or any kind of itis? Steroids might very well be involved. And immunosuppressants or cytotoxic agents, something to suppress the immune response. Okay? And I think that is a good place to stop, because we're going to start with immune complex mediated glomerulonephritis, which is probably what you're going to see in both of these cases. There is some sort of autoimmune and IgA nephropathy case, autoimmune, and then post-infectious, it's an infectious etiology, right? So we'll talk about these two. These are the most common test questions. I'm just letting you know as far as how to make the distinction between these two. And IgA nephropathy, much more so than post-infectious glomerulonephritis. IgA nephropathy is becoming more prevalent, so you might actually encounter that clinically. But truthfully, neither of these are what you would call serious, acute illnesses. I take that back. Acute illnesses, right? So we're talking about a glomerulonephritis spectrum disorder. What's going to be the hallmark lab on this side? Hematuria, blood, right? Blood, maybe minor swelling. So both of these patients, whichever one they have, is going to present typically with an episode of gross, painless hematuria. But what helps us distinguish between the two clinically is when it happens in relation to other illnesses. All right? So IgA nephropathy, the eponym you might see in older literature would be Berger disease, but we usually try to get away from these eponymous disease because they didn't tell you what it is. It's like ortho, right? You got to memorize what the hell Speed's test is instead of just saying what it does. You know what I mean? So try to get away from eponyms as much as we can, everything else besides ortho. So most common, like I said, this one actually is clinically on the rise. You'll see it more often. Why? I can't tell you that, honestly. But it's going to present with gross painless hematuria. But the thing that helps you distinguish this one is its temporal relationship to a URI or a sore throat, some kind of like upper respiratory type illness. All right? Usually either while the patient is still sick with symptoms of a URI, or maybe 1 to 2 days after it has resolved. All right, so synpharyngitic hematuria. At the same time as a pharyngitis, they have hematuria. That is an old term for it, but that's how we used to remember it. Okay, so this patient either is sick now, or they were sick in the past 1, 2, maybe 3 days. Is that clear? All right, and so what does this patient come to you? Because like, oh my God, I just had this sore throat, and now I'm peeing blood. Am I gonna die? You know, it's a pretty remarkable presentation because the patients are like scared of what the hell is going on. And typically it's not that bad, all right? But here's the background. Why does it happen? What is causing the inflammation? And why does it happen around the time of pharyngitis? That also is still fairly nebulous as to why. But this is what is going on, right? Or at least one model of it. So, galactose deficient IgA molecule. What does that mean? It means they have an IgA molecule that's missing one of the sugars that it's supposed to have. All right, it's an incorrectly built IgA molecule. Okay. So what happens in the body when you have something that is foreign, essentially, because it's not the way it's supposed to look? Antibodies, right? So an autoimmune sort of type of a disease here. So you have an autoantibody that recognizes this thing that doesn't belong and attacks it, binds with it, and that thing, that complex, deposits itself in the glomerulus. Okay? Is that easy enough? So you have something that's foreign, an improperly built IgA molecule, Body sees this thing floating around, doesn't belong there, attacks it, binds with it, and that thing, unfortunately, goes into rest in the renal mesangium, in the glomerulus. That's an autoimmune type disorder. And that thing is what causes the inflammation and the glomerular damage. Okay? So in the renal mesangium is where it goes. This is a picture of it. Again, just this improper structure, recognized and attacked. Why does it go to rest in the renal mesangium? Again, that's a great question. What is the renal mesangium? It's the cells in the middle of the ball of capillaries, that is the glomerulus. Those cells shrink and swell in order to affect glomerular permeability. Now, it's got this foreign substance deposited in there, so what happens to glomerular permeability? It's altered, causes glomerular hypertension as well, hypertension, and it causes blood cells and some protein to be spilled out in the urine. Okay? So that's the pathology of it, the microvasculature of it, if you will. Here's another picture of it. So healthy and IgA nephropathy on the bottom. And see these things right here? They don't belong there. And deposited in there, and they wreak havoc. So there's a picture of it for you. Right? But does everybody understand conceptually what I just described? This is just what I just described in a picture. Okay? Anything unclear? I see a lot of post-break temple rubbing. Yeah.
There's increased circulating levels. Why are they attacking?
Why is what attacking?
Are they genetically different?
Why is the IgA attacking?
Or why is the anti-glycan autoantibody?
It's attacking because the IgA is malformed. It's a galactase deficient, as a proper name for it. So imagine this thing is supposed to be built in a certain way. It's missing a leg, so it is essentially a foreign substance. And so that's why the autoantibody finds it and attacks it, because it doesn't recognize it. It's not supposed to be there. It doesn't attack regular IgA. It's just this stuff. And why is it there? I don't know. Does that make sense, though? Yeah. Yeah.
That was my question. Why is it genetic predisposition, or is it due to the illness?
I don't know. It has to do with illness. Like, again, the precise pathology hasn't really been identified specifically. Why does IgA nephropathy happen? Exactly. So that model is still also the most current theory of what happened. Now that immune complex does occur. That stuff is there, but is that all that is the reason for IgA nephropathy? That's still uncertain, but I don't know exactly. I don't know is the best answer I can give you on that. Anybody else? Okay. Go back to rubbing your head while I talk. So, most of the time there's nothing. Like, this doesn't walk in and say, I think I have IgA nephropathy. This patient walks in and my pee is red. And that's what they say. They don't even tell you, I was just sick. Because like I had piss, blood in my piss this morning. Then our job, well, let's do a history and physical exam and so on and so forth. And the key clinical indicator, past medical history, have you had any recent illnesses? Well, yeah, as a matter of fact. What? Well, yesterday I've been having a cold. I just got over it like 2 days ago. Bam, right? What goes to the top of our differential diagnosis? IgA nephropathy, all right? Mild edema, right? Hypertension. Already talked about that. Labs, CMP, this is what you need to get, right? We need to get CMP. Why? What's in the CMP that we need in kidney class? BU and creatinine, GFR, right? Yeah, and electrolytes just to see. They're probably normal. Most likely they're going to be. But let's see. And what do we expect? Probably evidence of renal disease. Remember, we're still in the intrinsic renal disease lecture. UA with micro, right? This story is going to get old, right? Repetitive. Hematuria, red cell cast, and some protein, right? Serum IgA. Okay, so we can use that level. We can draw serum IgA. It is not specific or even really that helpful, because if it's elevated in approximately 50% of the patients, what does that mean in the other 50%? It's not. So it's a coin flip if that's useful or not, honestly. Complement, all right, is typically normal here. And that is useful clinical information. So if the IgA is elevated, that's great. If it's not, whatever. So order it, but understand you're not gonna be able to diagnose off that. Complement levels here, this isn't an infection-mediated kind of thing, so our complement C3 and C4 are gonna be normal. That helps us differentiate from the next one, which is more of an infectious-mediated process. So it is useful to get a lab, even if it's normal. It's a pertinent negative, right? You guys have heard of pertinent negative, okay? Renal biopsy, necessary. Is it always done? No. Oftentimes this is treated preemptively based on clinical presentation in those other labs. When you get to nephrology, it may or may not be, but it's not always necessary. It's not always necessary to punch a hole in the diseased kidney, but sometimes it is, if it's a nebulous presentation or if it's uncertain. But again, mesangial deposition of IgA, of that IgA autoantibody complex, okay? So what is that? That's that malformed IgA and the thing that's attacking it bound together, and they go and rest in the renal mesangium, okay? And that causes that inflammation. This is a chronic problem, okay? It doesn't mean it rapidly progresses to a severe kidney injury, but this, if it isn't one, clinically important. So guys, listen, if this is in your patient's medical history, then you need to be aware of that and understand that you have to keep a close eye on their kidneys. It waxes and wanes a little bit, but this is something that will be a chronic problem. This patient will likely progress through the stages of chronic kidney disease faster, particularly if we're not taking care of their kidneys, because it doesn't just go away. All right, for some reason it stays. Becomes a chronic illness. So some patients, depending, like again, if this is somebody already with established chronic kidney disease and they get this, they may lose GFR real fast and never recover. Healthy patients often do just fine with it. We used to have somebody on staff here that was an IgA nephropathy patient. But we're really ultimately, do you remember me saying, side by side risk factors, proteinuria, specifically albuminuria, is worse as a prognostic factor than anything else, right? Independent of other risk factors, increased albuminuria has an increased all-cause mortality. You guys remember me going over that a little bit? So really we're addressing here is one, yeah, they're hypertensive, so we need to get that under control, but more than that, we need to keep their protein in the body. It's even more important because their hematuria will resolve. The IgA deposition will eventually resolve itself as well. We need to make sure that the glomerular permeability alteration also is minimized. And what do we do with that? What did I say the answer to every medication question is probably? An ACE or an ARB. That's exactly it. How are ACEs and ARBs going to affect reduced albuminuria? It's the Plato thing. Go ahead, spill it. What were you going to say?
I was just gonna say they're nephroprotective, like they'll.
They are nephroprotective, but how?
Lowers hypertension.
It lowers glomerular hypertension, but
Vasodilates?
yeah, it prevents ACE. ACE inhibitors prevent ACE from squeezing down on the efferent arteriole to cause increased glomerular back pressure, right? So if we open up that outpipe, the ball in the middle reduces its hypertension, so less protein gets squeezed out, right? So you're all exactly right. You got it. Yeah, I mean, you are. It is nephroprotective, very much so. Every kidney patient should be on an ACE or an ARB. Every diabetic patient should be on an ACE or an ARB for that exact mechanism. We're really affecting a reduction in albuminuria, and that's how we do it, okay? See, even if they don't have high blood pressure, we are going after protein. Most of these patients will be hypertensive, in the near term at least. Referral to nephrology, not necessarily urgently, but this patient needs to be. This is a chronic kidney disease, so they need to be seen by the kidney doctor. What will nephrology probably do? Follow them once a year and then punt them back to you. So what does that mean? You have to monitor GFR, BUN, creatinine, proteinuria, and make sure that you're not making necessary dose adjustments to their ACE or ARB. to maintain that proteinuria at a low level, or not at all. Does that make sense? So you will see these patients, but you won't necessarily have them on your, you're not necessarily following them for their kidney stuff, you're just making sure that the periphery is taken care of, okay? That's IgA nephropathy. So, synpharyngenic hematuria. This patient was sick or is still currently sick. Now they have red urine one morning. They come into you, and you take care of them with an ACE or an ARB. If you were to get a renal biopsy, you would find IgA immune complex deposition. Where? In the renal mesangium. Does that all make sense? All right. Now, let's contrast. These things go well together, contrasted. Post-infectious glomerulonephritis. Staying on theme with things not being ironically titled. Post-infectious. They are not sick anymore. They were sick a while ago. Temporally. It is different, right? So this patient had some sort of infection, most often a sore throat, but other things that can cause things like impetigo. But most often this is a sore throat, let's say 7 days ago, 2 weeks ago, up to 3 weeks ago, or maybe even a little bit more. Then they come in, I was sick, and this morning I got up and I peed blood. Okay? This is one of the reasons why we tell our strep throat patients to take all of their medication, not just their antibiotics, until they feel better. Does that make sense? Okay? This is one of those sequelae of an untreated or undertreated streptococcal infection. So, same as IgA nephropathy, right? Different, okay? Post-infectious. So this patient isn't sick. They weren't sick yesterday or the day before. They were sick a while ago. What's a while? 7 to 21 days. 7 to 30 days, whatever, a while. Okay? If they weren't treated or if they were undertreated, this is when the anti-streptolysin O titer may be useful. That'd be the only time that would be really useful. It's usually drawn just to see, but this isn't super common, to be honest with you, because patients usually take their antibiotics now. Patient education is important. Tell them to take all their medicine. But is anything else different? No, that's the weird thing, right? The other thing that's different from IgA nephropathy, in this case C3 and C4, will be low because it's been utilized. Okay? So it's being cannibalized by the infection, by the immune response. So C3 and C4 will be reduced, which is different. Again, pertinent positive here where it was a pertinent negative before. And here we have immune complex deposition in the glomerular basement membrane, okay? The GBM. So when I say subepithelial, that's in the basement membrane, okay? All right. But yeah, humps, subepithelial humps. Immune complex, same thing, right? Immune complex deposition, just different, has not IgA mediated here for some reason. This one is not a chronic disease. This one will resolve. If they still do have an underlying infection, just treat that. And most of the time, it's a short course of antihypertensive ACE or an ARB, right? ACE or an ARB is still the answer. To get them past the disease state, and then typically they do just fine. Okay? So this is monitoring. This is usually not inpatient medicine. Neither one of these typically are. But they still need to be seen by the kidney doctor, right? So this isn't like urgently, but this is like maybe an ASAP, or you give the nephrologist a call, say, hey, I think you've got post-infectious glomerulonephritis. Like, neat, send them over. So, okay? Now, put them side by side. There it is. Gross hematuria, typically the initial presentation, but that starts to resolve in PIGN. Throat culture, ASO titer would be positive on one side. Complement, if you want to add that, complement is low on the post-infectious side, normal on the other side. And then again, the big differentiator, how you see this, like somebody presents with acute gross hematuria with a recent illness, right? When was the recent illness? Okay? That's how you really go one way or the other. All right. Questions on those two? No? You all right? No? Hanging in there? All right. All right. HSP. IgA-mediated vasculitis is going to be very similar in pathology, like micropathology to IgA nephropathy, but they're two different diseases, even though they're both IgA-mediated. This one, the IgA attacks the vasculature, so it's a vasculitis. So what do you think is associated with that? With small blood vessel inflammation, what do you think you might see? Some kind of bleeding. Yeah, bleeding. Again, it goes with bleeding. It's just different. Skin bleeding, yes. But the microvasculature, not just in the skin, this patient can also have gastrointestinal bleeding. All right? So this is something that patients, this is almost uniquely disease of children. And patients will come to you with their kids very, very worried because their child is peeing blood and they have this insane looking rash that looks like meningococcemia. It looks like a meningococcal rash, and it's not. Also, just like IgA nephropathy goes with a recent illness. So this kid was sick, starting to get a little better. Now they're peeing blood. They have this crazy, ugly looking rash. Parents think they're dying. Fortunately, that is almost never the case. This is usually a self-resolving illness. And I'm going to show you the rash anyway. But again, very similar. IgA median follows a URI. Palpable purpuric rash. So a bumpy purple rash. Usually on the legs. Right? And different. If they have a meningococcal rash, what does that look like? Is it only in one place or another? It's everywhere. It's disseminated, right? Disseminated rash. Joint aches and pains, just like some of the other chronic kidney diseases we talked about that weren't exactly super acute, right? Aches, pains, myalgias, right? That's a nebulous sign of kidney disease, of renal disease, of acute kidney injury. Abdominal pain, because again, the microvasculature, grossly obvious on the skin, but it also can occur in the GI tract, so this patient can have abdominal pain and can even have some GI bleeding, like I said. That's a real bad case, so that's not a common outcome anyway. And then, like we said, this is still in the glomerulonephritis spectrum, so everything else that we would normally expect with what we've already talked about. But if you're a parent and your kid was sick, and then they start peeing blood and this develops, yeah, you know? So more often than not, an emergent presentation, like I'm taking my kid to the emergency room, but not an emergency, even though it looks really ugly, okay? Labs, everything's the same, just like IgA nephropathy, okay? And this is literally the same slide as IgA nephropathy, okay? And this is often the case. What do we do about it, right? Most times it's this side. So if you look at a patient who is doing okay, they can go home and we can just keep an eye on them. It's self-resolving. Kids are very stretchy and elastic. They get better. This usually doesn't translate into an end stage or a chronic kidney disease type problem. All right? So the most common of these treatment protocols is this right here. Just let them rest, give them some Tylenol. Why Tylenol? Why not Motrin? Yeah. Nephrotoxicity, exactly. We give them something that's going to metabolize through the liver and not their kidney. Now, what is this list? This list is causes or reasons why we would keep a patient in the hospital, right? inability for this kid to tolerate PO intake, severe GI bleeding, intractable pain that we can't control with PO Tylenol, right? So these are all just reasons why we would keep somebody in the hospital with us, okay? But more often than not, this is where we're going. Reassurance for the patient, reassurance for the parents. Referral to peds if peds hasn't already seen them. And Tylenol, go to sleep, watch cartoons. Okay? Which is reassuring. Any questions about that one? Same as IgA nephropathy, but in a kid with a rash. Fair? Okay? Now, switch. Anti-glomerular basement membrane antibody. What do you think these patients have as a lab that you could draw? They have anti-glomerular basement membrane antibodies. You're not supposed to have those because you're supposed to have your basement membrane of the glomeruli, or else you're going to die. Okay? So, it's an autoimmune type problem. Two different things. One, you talked about good pastures in pulmonology, because these also will attack the alveolar basement membrane, so you'll have hemoptysis and hematuria, and that is a often fatal disease. You can also just have one that only attacks the kidneys for some reason, and that is just anti-GBM glomerulonephritis. Neither are good. Remember the crescents we talked about? Profuse bleeding that fills up that crescentic space and then basically kills the ability of that nephron to do its work. That's what this does. Crescent formation is common in both of these. Okay? So this is often not a good outcome. Have you talked about TTP yet? And hematuria, or heme? TTP. Yeah. What is the treatment for TTP, guys? Huh? Plasma exchange, right? You have Adams 13 deficiency, right? You have to give that to that patient, right? So plasma, so you have something you don't have, so you're giving it to them. Here you have plasma therapeutic plasma exchange for a different reason, right? We have something that doesn't belong, so we're going to plasmapheresis them or give them a plasma exchange so they get rid of it, right? Does that make sense? So did he use the example for TTP, like the grass is too long, so the Adams 13 can't cut it, so it just breaks off, and that's what lodges in the microvasculature? You guys have any idea what I'm talking about right now? Okay. Anyway, that's my little heme review for you right there, so hope that helps. TTP, Adams 13, right? Do you have a little picture with a little pack? I don't care, I'm talking about something else. Anyway, so anti-GBM. So basically it's the invert. Like in that case, we're giving something to replenish the supply of something that patient is deficient in. In this case, we are giving the patient something and that doesn't have, right? We're taking something out of their plasma. We're giving them plasma that has no anti-GBM antibody. Because really everything else that we do is just sort of a band-aid. What we have to do is get rid of the thing that's attacking that patient's glomerular basement membrane and alveoli. So we have to clean it out. Okay, so what do? We smash the immune system with cytotoxic agents and plasmapherese them to try to get that out of there. Okay, but ultimately, this patient is a much more critical clinical picture than anything we've talked about so far. Like everything else is just, painless gross hematuria, no big deal. I used to be sick. This patient is acutely ill, all right, and getting worse, and the GFR is going to be tanking. And if you have good pastures, then they're also going to be coughing up blood, okay? Because of the basement membrane and the alveoli being attacked as well. But again, here's the thing that makes it different, right? Lung involvement and anti-GBM antibodies. So this patient has a clinical picture that's consistent with a rapidly progressive glomerulonephritis, a steep, sudden, sharp decline in their GFR. They're acutely ill. You get a panel of things. This is one of them. We're just talking about this. There's multiple other reasons it could be, but in this class, we're going to focus on anti-GBM antibody. Okay. Do all the other labs make sense, though? One, this is more of an autoimmune than an infectious disorder, so this is why complement is normal, just like an IgA, right? The only one where complement has been low is when we're talking about an infection, right? like an ongoing infection, or a resolved infection, excuse me. And then crescent formation. In case you couldn't conceptualize what crescent is, I drew this all by myself. You're welcome. And that's what a crescent is. This stuff right here in a crescent shape. What essentially that is bleeding. Severe bleeding into the glomerulus. Shuts down this nephron, but this is happening in basically every nephron, so this patient's kidney function goes way down really fast. Okay? If they're coughing up blood, it stands to reason you'll probably get a chest x-ray that's going to be pretty obliterated and ugly looking. And then again, we're getting rid of the thing. This is the problem. Everything else, immunosuppressants, cytotoxic agents that are really going to crush the immune system acutely, if you don't get rid of the problem, it's just a band-aid. All right? So the patient is still going to have a bad outcome, so we got to get that thing out. Does that make sense? And most often this patient has a morbidity and mortality are high. Okay? Here's a little note about me, right? If I start a slide with rare and it's in bold, just go past it, all right? It's a rare pattern. It's just another silly renal disease. It's very unfortunate. It's not a good morbidity or mortality. Just understand that, again, like I said, the slides are for future use. That one is not necessary. It's a bridge too far for this class. We could talk about a lot of other glomerulonephritis, but we're not gonna, okay? Any questions about the nephritic syndromes that we talked about? So we got IgA nephropathy, HSP, henox lung purpura. Those are similar, but they're different in the fact that one is a kid, and he or she has a rash, right? Talked about post-infectious glomerulonephritis, which, by the way, if you see post-streptococcal glomerulonephritis, that is the same thing, but that is old nomenclature. So if you do see that, that is exactly the same thing as post-infectious, okay? It's typically caused by a streptococcal infection, so that's what it used to be called, but makes sense? If you see PSGN, they're talking about the same thing. I will use PIGN because that is the correct nomenclature. But what is the deal with that? Post-infectious, 7 days to a month later, gross painless hematuria, complement levels on that one are low. That's useful. ASO titer might be helpful. And IgA nephropathy, renal deposition in the mesangium, and post-infectious deposition in the glomerular basement, subepithelial, so in the glomerular basement membrane. So still in the basement membrane, but just inflammation there, not attacking it, like in good pastures, or anti-GBM, right? Anti-GBM. Severe, sick, rapidly progressive, crescent formation, anti-GBM antibodies. And so the solution is plasma exchange, get them out, and put plasma in that doesn't have it in there, right? I know that's not going to tie a bow on it right now, but do you see how you could study those like that, side by side by side? You just see what the patient has, what the patient doesn't have, and the lab's patient history is going to put it all together for you, okay? And if just keep working on it, and if, come up with questions if you have them. There's a chart for you, okay? Nephrotic syndrome. What is nephrotic syndrome? What goes with nephrotic syndrome? Fat and protein. What kind of swelling? Lots. Perfect. Yeah, big swelling. Okay. Will they have hypertension? Probably. Yeah. Will they have some red cells in their urine? Probably. Yeah. Okay. Here we go. This is the patient presentation. This is why, and so 2 reasons you're going to see this. One, a primary nephrotic syndrome, common in kids. That the patient you'll probably see. That's the classic nephrotic syndrome patient. The swollen child comes to you. Like, what's wrong with them? The other is diabetes, which is going to be a nephrotic syndrome, a secondary nephrotic syndrome that we'll get to in a little bit, right? Patients with diabetes are very predisposed to developing a nephrotic syndrome. But our classic patient is going to be a kid who feels fine. Maybe they have some foamy, maybe a little cloudy urine, and all of a sudden they're swollen. And then they come to you. So swollen kids, one of the things you know, once you quit, you know, obviously rule out the fact that this kid isn't having anaphylaxis or some sort of life threat. It's probably nephrotic syndrome, okay? So diabetes, okay? Diabetes, secondary causes, right? Everything here is a secondary cause. We're gonna talk about primary causes and secondary causes. Everybody know what I mean when I say primary and secondary? So a primary renal disorder means it just happens in the kidneys for some idiopathic reason. Secondary disorder means that nephrotic syndrome is a symptom of the other thing, right? So edema, fat, protein, okay? As you lose more oncotic pressure because you're peeing out your protein, your albumin, the swelling risk goes up, all right? So we got a slide that goes to this, but let's do it as a thought problem. If we're losing plasma oncotic pressure, what else is happening to our blood?
Losing clotting factor? Or losing anti-clotting?
You are losing anti-clotting factor. You're not using, actually it's coming out in the urine, like protein C and protein S are being lost in the urine with the protein, so that is almost right. Yes, that is happening, but what else is happening? Huh? Hemoconcentration, right? Your third spacing fluid from the plasma compartment because you're losing oncotic pressure. So what happens when you have relative hemoconcentration? What happens when your blood becomes syrup? Yeah, clotting, thrombosis. Your platelets bump into each other and activate, and they form clots, and the clots form everywhere. So you have an increased clotting risk, and that is really the risk of nephrotic syndrome, one of the biggest ones. Not just the third spacing and the potential development for infections because you have static fluids sitting around, but the hemoconcentration and the increased viscosity and the increased thrombotic potential, right? That's what really can affect a real negative outcome for your patients, right? And that's what we really have to pay attention to. So good. Heavy proteinuria, hyperlipidemia, especially triglycerides. So yeah, these, I mean, you know, one of the rare occurrences where we'll get lipids in children. This is something you need to get. These are, again, the general signs. We'll talk about the individual diseases here in a sec. But everything on here you've seen already. Oval fat bodies, right? Fat, globules of fat in there. Lipiduria, lipid-rich casts, fatty casts, right? Remember those? Okay. And decreased serum albumin. Right? So again, albumin is one of the parameters on CMP, so it's really important you get the CMP here. Hypoalbuminemia, this level, this threshold, isn't the threshold for low albumin. It's a threshold for when the risk of thrombosis starts to become very high. So in this patient's serum albumin is less than 2, they're at a very high risk for forming those thromboses, okay? And we got all this. Hemoconcentration, right? We're trying to make up, the liver is increasing clotting factors because we're losing them anti-circulation. We're losing the zymogens that inhibit the clotting cascade in the urine. So it's like a double-edged sword there. And then, like I said, the platelets in the relatively syrupy and thick blood are bumping into each other, causing platelet activation. So it's just this recipe for disaster for clot formation. Have you guys done the clotting, the blood dyscrasias and stuff already? Yeah. So you guys see, like, just that is a recipe for disaster. Okay. So that's really the thought. So then we have to maybe, when we get below 2, you need to actually give this patient albumin to replenish that supply while you're doing other treatments. So that is something that's critical to make sure that this all doesn't happen, all right? And then a lot of times, especially in kids, biopsy will be sort of not done, just treated preemptively. It's a pretty classic presentation, and there's like 90% of primary is one disease in adults, one in pediatrics. That will make sense in just one second. So a lot of times, again, we don't punch holes in diseased kidneys if we don't have to, all right? And then slow the progression of renal disease. And I told, it's the same answer as before. We're keeping the protein in the system. That's the problem. So we're going to try to decrease glomerular pressure with our old friends, ACEs and ARBs. Okay? That's going to help in the long term, right? Acutely, we may need to pull some of this water off of them so that they don't develop pneumonia, spontaneous bacterial peritonitis, thrombus, right? We might need to get some of this water out so that they might be on diuretic therapy in the short term. But they're going to stay on ACEs and ARBs and then anti-hyperlipidemic therapy, especially for our adult patients. And then again, in this particular case, not everybody, but in the case where this patient is at a severe thrombotic risk, replenish their albumin, okay? And anticoagulation, okay? Does that make sense? General, that's all general nephrotic syndrome stuff, okay? We're getting to a stopping point, I'm losing the audience. I know we only have 10 minutes left anyway. Let's do this one, okay? Because that's everything, that's the important stuff. And again, that seems like a lot, but it's everything that we've done it over and over again. Nephrotic syndrome, lots of swelling, losing protein, right? Peeing out fat. Patients at risk for thrombosis. Now we know it's at, if they're less than 2 grams in the serum, that's where they're severe risk, so we give them back. Protein. And then ACE and ARBs, I already told you, that's kind of the answer for almost everything, right? ACE and ARBs to reduce proteinuria. Because proteinuria is fat. There you go, write that down. All right? So seriously, if you put them side by side, not too much. Now what is going to make these identifiable from one another? Let me tell you, minimal change disease. 90% of the patients in minimal change disease are children. Children are small, minimal change disease, right? That's the way you were kids. Membranous nephropathy, most likely in adults. I don't really have a good one for that, just kids, adults, and then focal segmental really goes with diabetes. Children, minimal change disease, kids, small things, right? Children, minimal change disease, right? Really what it means is on a examination of it under the electron microscope, the change in the glomerulus isn't dramatic. It really literally means minimal change. Like the overt glomerular permeability, the overt injury or adjustment to the glomerulus, it's not really that profound, okay? But for us, you can just remember that minimal means small, and so kids are small, okay? Usually primary, like I said, just happens, and it does exactly everything I've already been saying. Most of the time, that's what gets patients brought in, either swelling of the legs or a big swelling of the face, a big swollen kid, all right? And all of those other things in the lab we have already talked about over and over. Proteinuria, hyperlipidemia, azotemia. What is azotemia? Increased BUN and creatinine, decreased GFR. Let's not forget we are still talking about we're talking about intrinsic renal disease, right? Intrinsic renal disease. So the labs for intrinsic renal disease are going to be what we expect here. So if I say nephrotic UA findings, have we gotten to the point where we can understand what nephrotic UA findings are? Lots of protein, maybe a little bit of blood, fat, oval fat bodies, fat casts, okay? Hypoalbuminemia, okay? And then, does everybody know what effacement, anybody know what effacement means? Huh?
Smoothing out.
Thinning, yeah, a thinning. Like cervical effacement when a woman is in labor. cervicus thinning, right? So cervical, so thinning of the podocyte foot. But what is a podocyte? It's a foot cell, podocyte, foot cell, right? It's one of those octopi that are sitting on top of the glomeruli, right? Those podocytes are their little feet, and they're thinning, right? So that doesn't have a dramatic look to it on a specimen, but what that does is increase glomerular permeability, right? Those podocytes expand, contract, get closer and farther apart in order to change glomerular permeability. So if they're thinned out, they're too far apart, protein can escape. That's minimal change disease. What do you think the treatment is? Acyclovir and steroids. There you go. Right. Steroid responsive MCD is most common, okay? So, it's a primary problem, right? Usually we will give these kids an ACE or an ARB. They might have to go beyond corticosteroids into a more, in a true immunosuppressant or a cytotoxic agent. But for your case, understand that kids with MC, swollen kids with nephrotic syndrome need steroids, probably an ACE inhibitor as well, to maintain protein, and then children typically do better. Side by side, adults that get MCD do worse, okay? But kids typically do just fine. And that's it. Any questions about minimal change disease? We're done. I can't answer it yet. We're finished. But does that make sense? It's just nephrotic syndrome. It's in a kid. Primary effacement of podocyte foot processes, if you need to remember that, and steroids. That's the only thing that makes this one different. Okay? Everything else is general nephrotic syndrome labs that we've identified. Okay? Any questions for me? Tomorrow we'll do the rest of this slide deck, and the rest of this we're getting into what I like to call the potpourri section. Anybody watch Jeopardy? Potpourri is just like the general. We're going to go into like the general category. So the lectures are going to be a lot shorter, sweeter, to the point, like here's what you need to know about this thing, because a lot of the remainder of the stuff we're talking about is going to be kind of unique and zebratic, if you will. But any questions for today? All right, I'll see you tomorrow.